Hello and good afternoon. Thanks for joining us for today's Healthline. I'm Shannon Brinius. We like to focus during Healthline on ways to live a healthier, happier, and pain-free life. And we're going to be taking your calls and answering your questions live in the studio today. And for that, we'll be opening up the phone lines. Now, as a reminder, we want to make sure that when you do make a call to us, be sure you're in a quiet room when you call. Turn your TV sound all the way down. That'll help all of the audience hear you much better. The number to call is 318-219-4569. And today's topic, we're going to be talking about sports medicine and orthopedic injuries. And joining me here is Dr. Callanan. And so glad that you could join us today to talk about this. First question that we're going to be talking about is rotator cuff injuries, correct?
Yep, absolutely.
So first of all, I kind of know what a rotator cuff is, only because it seems very obvious. It's rotation of your shoulder, but why don't you explain it to us?
Yeah, that's a great question, and that's obviously one of the biggest things. People hear rotator cuff, it's a very common injury. People come in all the time. Most people don't know what the rotator cuff is. So I bring a little model. I mean, it's a little bit easier than hand waving sometimes. When we're looking at things here to orient patients, this is your collarbone coming over here, and this is your shoulder blade or your scapula right here. And it comes over, and basically, when you're looking at kind of these tendinous attachments over here, this is representing the rotator cuff. The rotator cuff proper is actually 4 muscles that attach from your shoulder blade that reach over and attach from the posterior to the anterior side, you know, the back from the front of the shoulder, and they basically control normal motions, reach and grab and push and pulling. And so all these fire in different capacities, and that's really what kind of gives you some strength and helps keep basically the ball and socket centered on itself while you're doing these complex movements.
Who needs to have rotator cuff surgery if it comes to that?
Yeah, so rotator cuff surgery is really resolved for, there's a spectrum where you could probably, go on for a whole hour talking about the nuances of different cuff tears, but in general, when I'm seeing a patient, if somebody's having pain, there's a lot of conservative stuff we can start with first, because not every rotator cuff tear needs to immediately jump in and have surgery. There's steroid injections, there's anti-inflammatories if patients can tolerate it, and there's also formal physical therapy, which can be very effective tools. If somebody's either failing conservative treatment, that's an indication to get more imaging to look and see if it's torn. Or if I have a patient that comes in, they trip and fell, and sometimes they go to the emergency department, they get x-rays, they say, hey, you didn't break anything, but now that patient can't lift their arm overhead. If they come in with frank weakness, that's usually the sign of a big tear. So usually pain and weakness are the bigger indicators where I'm a little bit more aggressive about getting an MRI to look at that cuff, because we do know in active functioning people, if you have a large retracted cuff tear, a lot of times you're not going to tolerate that well.
And let's talk about those conservative treatments, because of course those are the ones that really are the lesser cost, the lesser PT needed afterward.
Absolutely.
What are those?
The lesser downtime, exactly. So I tell all my patients to put them at ease when they come in the first time you see me is, if I can get you better with the simple things, that's always the goal. I love shoulder surgery, I do a ton of shoulder surgery, but at the end of the day, not every shoulder needs surgery. In fact, the large majority that I see, we can get better and get to an acceptable amount of pain on a day-to-day basis without having to jump into surgical intervention. So getting back to it, a lot of people, when they develop rotator cuff issues, it falls more into like tendinitis more than anything else, okay? There's different ways that the shoulder can develop that can predispose people to getting tendinitis, and certainly occupation, activity levels, what your hobbies are, people playing pickleball or tennis or racket sports, a lot of repetitive stuff. I have a lot of people that love gardening, so you're doing a lot of weed pulling, a lot of repetitive stuff for hours on end. All these things really can contribute to that. And so conservative treatments, I usually like to start with steroid injections if a patient can tolerate it, they don't have bad diabetes or some precluding factor, and some anti-inflammatories. Again, some people can't take those. That's like the ibuprofen Motrin family. Trying a prescription strength one is good. Saying they don't have underlying medical comorbidities where they can't have those things, that's always a great start. We have home-directed therapy plans that we can do, but I also try to encourage patients to try to visit a formal physical therapist. We got a lot of great therapists in town between Willis Knighton, we got the training ground, we got Foltz Therapy. There's a lot of great options in Shreveport, and these people are very well-trained professionals at getting people better. Even if they have partial tears or even sometimes full thickness tears, you can compensate with the right treatment plan without jumping into surgery.
What are some of the advancements that have come out when it comes to the types of surgeries we're talking about?
Absolutely. So, rotator cuff surgery, even since I've been in practice, has evolved as far as, the same idea is when we're going in there, let's say in a full-on tear, When you think about these tendons reaching over and attaching here, the biggest problem with the tear is, number one, the blood supply is not great to these little tendons. So the ability of the body to get nutrients and healing factors to that is already a little bit diminished. And then number two, these muscles all retract in one plane. So certainly the coordination of them can help with the advanced movements, but if you tear one of your rotator cuff tendons, that muscle is pulling that thing away from the attachment point. So it's constantly under tension. That's why they tend to propagate over time. So whenever we're going in to do surgery for a tear, the goal is to put anchors in and restore it back to the footprint to try to get it to scar back to the bone. That's the ultimate goal. So from a rotator cuff repair standpoint, some of the things we've had most recently that I've adopted in practice are, we used to, from an anchor standpoint, just have these big hard body anchors. That's a larger kind of channel that we have to make to screw these things in. And rotator cuff surgery in general tends to be a little bit more painful for patients. So anything we can do to make that lessened is always beneficial. So we would put these traditional hard body anchors in, and I do think subjectively patients had a little bit more pain. You got to think about it. We're making big kind of defects in the head. They're very effective anchors, but at the same token, it's a pretty small footprint, big anchors, and it would be a little bit painful. Now we have all suture anchors, which are much more small, low profile, soft body, so not nearly as much bone disruption, but still excellent fixation strength. And they're small enough where we can actually get more of the anchors in there to get a wider footprint of coverage and a little bit more structural support on these repairs. Subjectively, patients I see, especially early on, where usually it would take sometimes 6 to 8 or sometimes up to 3 months before they really start turning that corner. Nowadays, even 2 to 6 weeks, I start seeing improvements of the pain scores already, where traditionally I'd have to be telling them, hey, it's going to take a little bit longer. So I do think outside of the benefits of bone preserving and having a little bit more fixation points, the actual post-op pain's a little bit better too. So that's one thing we've adopted.
Is there less inflammation too when you're talking about those type of suture anchors?
I think that the inflammation is probably very similar. I think if you were saying, is there less inflammation in the bone from less trauma, from less tracts? Yeah, you can make that argument. And I do think bone pain from the big anchors we used to use certainly was a factor in there. Other things that we do now too is the amount of augmentation that we have. So some people will come in, and when you're thinking about the spectrum of rotator cuff tears, there's the traumatic tear where you slip and fell, or you're picking up something heavy, felt a sharp pain, and you just start having pain and weakness. And there's also more degenerative. The rotator cuff, and kind of the dirty little secret is that thing is made to kind of degenerate over time. We've done population studies where they literally took all comers that were 70 and said, hey, we're going to get MRIs of the shoulder, whether or not you have shoulder pain, and more than 50% of them had rotator cuff tears, and some people didn't even know it. Oh, wow. So that's what I tell all my patients. Sometimes if you come in and you've had a chronic kind of shoulder pain, or you have new onset shoulder pain, you may have had an underlying tear, and it's just getting to the point where it's meeting the threshold, or the body's saying, hey, we can't keep doing what we're doing.
Livable pain, and it became unbearable.
Exactly. So we still can try therapies and try to get that stuff better, but in those more degenerative setting, that tendon quality sometimes can degenerate like anything else. And so with that repair, your repair is only as good as the native tissue underneath. So if your biology isn't optimized, the tendon quality is not as good, or let's say somebody comes to me for a revision. They had a prior repair 10 years ago and it's retorn. Then you got to start thinking about augmentation. And so what we can do now is we have different things from bioinductive patches that are actually made from bovine, cow collagen, that you can put on there that gets ingrowth, so you can thicken things up. And we also have human dermal allograft, meaning cadaver skin, that we can actually anchor in that has a lot of tensile strength, and put that on top of repairs to give a little bit more biology, number one, and a little bit more robustness to the repair, if you will, some augments. So there are some things that we've come along that I think have been good overall for trying to get that healing rate improved.
It's a bit of the Frankenstein story, but it's all for a positive health outcome.
Absolutely.
We do have Steve on the line. Steve, thank you so much for calling in. Make sure your TV is turned down right now, Steve, if you're wanting to ask a question. And why don't you pose your question to Dr. Callanan?
Yeah, I was just listening to him talk about the alternatives after you've had multiple repairs. My wife just recently had 2 back-to-back rotator cuff repairs, and it's torn again. And our doctor's trying to send her off to someplace else, and I was wondering, is there something else that she could do? Because you can look at the x-rays and see that it's half torn from the screw to the frontal part of the rotator cuff, and what could you do to replace that tendon?
That's a great question. And that when you start getting into the revision setting, some of it depends on the patient's activity level, what their ages are, but it's not uncommon that I'll see people that have had multiple prior surgeries where they've been remotely. Their first one was 10, 15, 20 years ago, and then they've had a revision, it fails again. And you got to think in those scenarios, you start losing a little bit of that tendon over time. Every time it re-tears, you're dealing with, much kind of junkier tendon, a little bit more degenerative setting. So there are salvage procedures, things like superior capsule reconstructions, things called lower trapezius transfers, where you can actually transfer some muscular tendinous structures basically to more or less compensate for not having a rotator cuff. They can kind of fill in the gap, and that's for younger, more active patients. But to kind of segue, when I start getting patients that are getting late 50s to early 60s on up, and they've had a history of these recurrent tears, sometimes shoulder replacement is an actual option, and that's really where we start talking about the different types of shoulder replacement. A lot of times, if somebody's failed multiple cuffs, depending on their age, if they got a little bit of arthritis and other contributing factors, thinking about reverse total shoulder is not a bad option. It's very predictable. You're not waiting for a little tendon to heal again, because one thing we know from literature is after the first revision, certainly a second revision, the outcomes don't get better. They tend to get a lot worse, and you're basically at risk of putting somebody through the same procedure again with the exact same outcome. So I guess there's a broad spectrum of things that you could do, and it really depends on the patient's age, activity level, and kind of what the actual tendon and tear pattern looks like at this time.
Well, Dr. Callanan is based at the, thank you, Steve, for that question. And Dr. Callanan is based at the Piermont Street, Willis Knighton, what is it, orthopedics?
Yeah, we've kind of rebranded where we used to be the orthopedic clinic, and that's kind of what we're still known as, but it's Willis Knighton Orthopedics and Sports Medicine at Piermont, because we have our Bossier group that's, orthopedic and sports at Bossier. So we're down at the Piermont spot.
So Steve, hopefully you can give a call to them and maybe have a follow-up if you want to. But right now, if you want to ask a follow-up question, we have Dr. Callanan here. Is there anything that his answer sparked you to want to ask again?
Yeah, absolutely. Because my wife's a very active 66-year-old and very healthy, and she had these tears in less than 4 months apart.
Yeah.
From the original to the next one, and this is, I think, almost like a spontaneous tear.
Yeah.
And
I would tell you this.
We're kind of worried.
Yeah, in that scenario, honestly, if I have an active 66-year-old and they've already had a couple tears, that's when I would start thinking about reverse total shoulder. And reverse total shoulder is called a reverse simply because you're switching the ball where the socket is and the socket where the ball is. This actually was adopted probably 20 years ago. It started really coming to the United States in any capacity, but the Europeans were doing this prior. The reason that we use this, and the predominant reason we use this, is for what's called rotator cuff tear arthropathy, where if I have a patient, basically what you're describing as your wife, where she's had multiple recurrent tears and she's in that perfect population of active people 65 and up, the healing rates start going down again when you start going through that process. So again, instead of putting somebody through a salvage procedure or trying to do a revision cuff, a reverse total shoulder is not a bad option. It's actually a very good solution as far as predicting, number one, pain control, and number two, trying to restore as much function. So by switching the ball with the socket, if you think about the role of the rotator cuff as is, the four muscles that attach to the ball over here, if you tear this thing, you no longer have that control where that ball's centered on the socket. You have the pain and the weakness associated with it. So the ball can start riding up underneath the roof. A lot of times you'll see the patients kind of shrug when they lift their arm, and we call that pseudoparalysis, but certainly pain and weakness is usually what we see. So by switching ball and socket, getting back to that, we're changing what's called the center of rotation of the shoulder. And by doing that, this, number one, keeps that head in a better position because it's rotating just around the ball. And the primary driver of the ship now is your deltoid muscle, and everybody has a shoulder muscle. So as long as you have a good shoulder muscle, that is now mechanically driving the ship, and you're basically bypassing the rotator cuff. And at the same time, most of these patients tend to have a little bit of arthritis, so you're kind of killing two birds with one stone, kind of addressing all the issues. This is quicker compared to like a rotator cuff repair. I only keep people in a sling for about 2 weeks. You're doing therapy right away. At 2 weeks, I let you start doing all your daily activities. By 6 weeks, I tell you do whatever you want with it, okay? So it is a little bit quicker recovery, and it's much more predictable than going in for a third time, or even some of these salvage procedures are good, but that would be more of a patient population with 40s to 50s where I would really try to do that just based on what you're trying to get, because ultimately in any type of salvage with rotator cuff, if you can't repair it, you're trying to get them far enough down the road where if they need something, they'd be a candidate for this. I think at 60 66 if you're active, this is a great option for somebody that's had multiple recurrent cuff tears.
Is that maybe, as you were talking about, maybe more of an option than when you're talking about knee replacements? I mean, is it better? Maybe you're leaning more towards something like that?
Yeah, I think so. It's a little bit, with the knee, it's really just arthritis is your predominant reason why you're replacing. There's standard shoulder replacements where you're just resurfacing the ball and socket. Those tend to be younger patient populations where the rotator cuff is intact. Because if you were to put just a resurfaced shoulder in there where you give a new shiny ball and a little socket, if that rotator cuff is torn or it doesn't heal right, they're not going to be happy because they're still going to have the pain and dysfunction from not having a rotator cuff. They would need to have a reverse. So to your point about that, if you're looking at it just like with knees, it's purely, for the most part, just bad arthritis is the reason people get knee replacements. Sometimes fractures or precluding issues, but that's a little bit different for the shoulder because you have so many other factors like the rotator cuff. It's kind of multimodal, not just arthritis like you have in the knee.
Okay.
But yeah, in younger patients, kind of getting to that too, I guess as far as newer technology, I get some guys in their 40s, or early 40s that already have really bad arthritis. Some of them were athletes, some had prior shoulder trauma, some of them just love bench press,
I was going
and
to
it's
say
one of those
bench
things,
pressers,
over time, it's a culprit, and shoulders wear out like anything else. I tell everybody, think about the tires on your car. That's like your cartilage. That cartilage is living and can replenish, but over time, it can certainly wear out. So when you have these really young guys, the historic problem with doing shoulder replacement is that that little plastic liner can wear out over time. The earlier in life and the more active they are, those things aren't made for bench press. They're not made for a guy really getting after it. They're going to wear out, and you got to tell them, hey, just like with getting a knee replacement early in life, you're probably going to need a revision at one point. That's why we try to push it down the road. So the good thing now is we actually have partial replacements that instead of stainless steel, they're made out of what's called pyrocarbon. And pyrocarbon is actually less dense than the bone, so you don't even have to resurface the socket. Traditionally, when we do a partial replacement, the stainless steel ball was more dense than that little socket. It would grind that socket down to nothing over time. So you lose bone stock, makes it much more challenging if you need a revision surgery down the road. The pyrocarbon being less dense, you get a smooth bearing surface to address the arthritis, but you don't get that wear effect that we used to see with the metal, and you can let them do whatever because you're not worried about that little plastic liner wearing out. Where you can get back, I basically say whatever you feel comfortable doing. So in younger patients, I do think it's a much better option than historical things that we have had where they just don't have the same restrictions that we used to. But again, very specific indications, young, active, healthy, good rotator cuff, bad arthritis. So, there's a broad spectrum of shoulder replacements. It's not kind of just A or B that people fall into.
Well, we do want to remind people, and we appreciate you calling in, Steve, and asking those very informed questions. And hopefully it does give your wife some help and maybe some guidance as she moves forward in her health journey. So again, the number to call if you'd like to ask questions of Dr. Callanan is 318-219-4569, 219-4569. And the question, or the number that you see is right there on your screen. All right, we do want to get to some other questions that we have. So tell us about shoulder arthroplasty. Am I saying that right?
Yeah, you nailed it. That's basically shoulder replacement. Arthroplasty, and that's always one of those things patients ask about. Replacement and arthroplasty are synonymous. And so knee arthroplasty, having a knee replacement, hip arthroplasty. So sometimes we throw out these terms, and it, just off the top of my head, I'll throw them out there. And patients, you get so used to talking to other docs and stuff, you don't realize most people are kind of looking at you like, what's an arthroplasty? But that's exactly what we were just talking about. It's a shoulder replacement. It's just a fancy way of saying replacement.
Are there different ways that you can now utilize arthroplasty in terms of, I guess, diagnosis and figuring out what the best solution is?
Yeah, it's always a tool in the toolbox. With rotator cuff issues in older patients, usually that's the reverse. Kind of the middle of the road patients with a good rotator cuff, lower demand, standard, shoulder replacement, resurfacing both sides, I think is a great option. Younger patients, I'm leaning more towards the pyrocarbon, the partial replacement. But then another category is when I'm on call or if somebody slips and falls, like we had a lot of this with the ice recently, bad proximal humerus fractures. If you break your upper arm bone, Simple fractures, a lot of times we can treat with a sling. You don't have to jump in and do surgery. Traditionally, plates and screws are good. Sometimes, though, the older we get with less bone density, people come in and that shoulder's just blown to pieces. There's multiple little fragments. So you could certainly try to go in, depending on the patient's age and bone quality, and say, hey, let's pull all this together. Let's try to use a plate and screws and put all these little fragments back. But there's always the risk it doesn't heal, or that bone had such a bad injury at the time where the blood supply is disrupted and it dies over time. So a lot of times, especially in older patients that are still functional, we'll jump to a reverse total shoulder. And there's very specific ones that are made for fractures, where we actually have fracture stem ones where we can get extra fixation down the stem. We have little adaptations on the actual prosthesis where I can pull the actual attachment sites of the rotator cuff back over to the stem to try to preserve and try to help with outcomes and function, because that's one of the biggest things, is maintaining as much of that rotator cuff as you can.
And I would guess that this is an area where you're seeing advancements as well, like the ones you mentioned.
Oh yeah, absolutely. Shoulder arthroplasty is certainly, if you even look over the past decade where we're coming along with the different types and designs, when people traditionally would look and read online, sometimes people come in and they say, well, if I get a reverse, I can't lift more than 10 pounds or something. Well, historically, people just, the function wasn't great. The amount of restrictions they had was much greater than what we know now, because we just didn't really know design. We didn't know implant positioning, all this stuff. We're so much better now. I will say a good reverse is almost negligible, kind of the difference when you're looking at function and activity levels between somebody getting just an anatomic resurfacing. And so certainly if you get those older populations, if there's any type of wear and tear or partial tears in the cuff, I'm going to hedge my bets towards the reverse total shoulder, because I know they'll do great, and then you're kind of protecting against eventual wear out of the cuff too.
And something even worse later on.
Yeah.
Chet is on the line joining us this morning, and you have a question for Dr. Callanan. And a reminder, turn down the volume on your TV if you're asking this question right now. Thank you, Chet. Tell us what you want to know.
A few years ago, I was in a car accident where I was T-boned, and it tore the tendons on my collarbone, and they said it was a dislocated shoulder, but it had also tore the tendons to the collarbone.
Mm-hmm.
And I know you probably know exactly what it looks like. And my collarbone pokes up high,
Yep.
my shoulder kind of droops, and they told me at the time I had to go to Ochsner, and they told me it was an unsuccessful surgery, and if I wanted a second opinion, to call New Orleans, but that the one in New Orleans was the doctor who said it was unsuccessful. And I'm
Okay.
67 years old, and I've got a pacemaker.
Yeah. So it sounds like you had an AC separation is what we call. So, an AC separation, to your point, is where the collarbone meets the shoulder blade, you do have a capsule right here. And you also have two ligaments that attach to this prominence called the coracoid. It's the conoid and the trapezoid. So if you have enough force, you can basically disrupt those so your clavicle sticks up. And that's called an AC separation.
So
And
the clavicle on the front or the clavicle?
usually up high, yeah.
Okay.
It usually sticks up a little bit higher, where you'll see almost like, poking out. Sometimes it's really tenting the skin. But a lot of times, you'll see this even in football players. They'll get a separation, and I've covered collegiate football, and you'll see half the players sometimes, they got prominent AC joints just from playing and getting hit and stuff. So a lot of times you can conservatively treat it based on how much disruption there is. But certainly, did you say you had an operation on this thing already?
No.
Okay, yeah, they were just worried it would not be successful. Is that what you're telling me?
Correct.
Yeah, and I will say the outcomes in patients that are middle-aged or older, certainly you can make the argument, depending on the grade of separation, is it worth your time to go in there versus the risk of that thing basically losing the fixation and being back to square one. There's always that risk with AC joint surgery, but I will tell you, I have fixed some chronic ones. If it's really bothering a patient, that's the biggest thing. It's one thing if you have a prominence and you had a chronic separation and you can get by and you don't really care what it looks like and it doesn't hurt you. But it's another thing if, it not only is something where you don't like the way it looks, but it's also giving you trouble. There are sometimes chronic things or solutions surgeries that we can do for chronic ones, where you can basically put implants in to restabilize this, and we usually pass a cadaver graft around to give a little biology to try to reconstitute some of those ligaments that are lost. So there's always usually something we could talk about. It's rare where there's a case where I'd just say it's not worth your time. Now, being as far out as you are, one of the biggest determinants of whether or not you're a candidate is how stiff this thing gets. Because at the end of the day, if this thing has been sitting up for a while, sometimes you can't reduce that clavicle or that collarbone anymore, and it would be real tough. That would be tough to say it's worth your time to go through that surgery, just because the amount of torque is going to be higher than anything from most of our implants, and I think the failure rate could be there. So some of it also depends on clinical exam if you can actually still reduce your collarbone or not.
And Chet, we really appreciate you have a follow-up. Go ahead.
This is my dominant arm.
Yeah.
And I use it every day, but I do, periodically.
Yeah. I'd be happy to take a peek at you, if you want me to, give you my opinion and see kind of what your exam is and what your options are. If you would be a candidate to try to do a chronic reconstruction, I would certainly have that conversation with you.
All right, so Chet.
Okay.
Yeah, so Dr. Callanan's office is on Piermont. It's at the Piermont, Willis Knighton at Piermont, Orthopedics and Sports Medicine.
It's in the Portico
office.
Center.
Yeah, it's in the Portico Center. So give them a call and you can make an appointment.
Well, I go there right now to see Dr. Lee because I've also got a broke bone in my lower right leg.
Okay.
And I see Dr. Lee for it right now.
So you're a frequent flyer, so that's good. You're already very familiar with us. Dr. Lee's my good partner, so I'd be happy to see you too.
I try not to be a frequent flyer, but it's just fell off a ladder, broke my leg, and I'm at the end of getting my boot off at the end of February.
Well, you might just roll into another one.
Yeah, you could roll into it. It's not a bad thing being a frequent flyer. It just means you're an active guy. So, but we're happy to see you.
All right. Thank you, Chet. Thank you so much. And I think we're running out of time to take any new callers, but we really appreciate Chet and Steve, everyone who's called in this morning. And I wanted to ask you, you were talking about like some of the recovery times involved. Mm-hmm. What about limitations after some of these operations that you're mentioning?
Absolutely. So rotator cuff surgery, especially in younger patients or more active, the ones where we really want to get that thing to heal. At the end of the day, if you can get the rotator cuff to heal, my goal is to let you get back with no restrictions. It's not something where it's like, okay, you can never do X, Y, Z again. We're always in the business of keeping people moving. And so that's the goal of every surgery, help with pain, restore function, and ideally get you back to what you want to do. So when it comes to, things like reverse total shoulders, if I have somebody that's coming in and, they got a bad shoulder and they're saying, I still want to try to go, bench 300 or something, that's not really the operation for you. I'd basically say, hey, when we're past that point where we don't want to do these things anymore and the shoulder's bothering us, we want to function well and get some pain relief, that's when we start talking about some of these prostheses, because there are limitations to what these are designed for. Just like if you get a hip replacement, if you still want to go out and run marathons every year, it's really not what that's for. Mm-hmm. All right, they do have some
skiing
design.
Or things like that.
And even skiing, though, I would let you ski. I'd let you do whatever you want. I have a lot of people that ski with reverses. I have a lot of people that ski with rotator cuff tears. So, again, there's a pretty broad spectrum of what we let you do. But depending on, especially with like reverses, there are select things where we'd say, hey, this may not be the best idea. But most activities are still within the realm of possibility after shoulder surgery.
Fantastic. Well, you've certainly given us a lot to think about. Is there any, in our final minutes here, is there any words of advice that you could pass on to people? Because it seems like preserving your rotator cuff would be the best option for all of us.
100%. I think a good warm-up program, and I mean getting in with like a trainer, like I said, I mentioned the training ground, but really even getting some physical therapy exercises, some things where you can isolate the rotator cuff to work on strengthening if you're going into the gym, or even just warming up with isolated or very specific rotator cuff type warm-ups can preserve the shoulder and really get things firing and kind of lead you on the right path so we kind of prevent these things. I mean, the ultimate goal is you don't end up in my office at all. That would be the ideal solution for most people.
Because I think a lot of kids, even some, athletes who are adults, but doing it as a hobby, I think they tend to discount the warm-up. I know I did when I played a lot of tennis.
It's really important. A lot of people have weaknesses and imbalances, and in the gym, a lot of people aren't addressing the cuff. They're looking at the bigger muscles you see in the mirror, but that's really where knowing and kind of figuring out different things that you can work on cuff strengthening and shoulder mechanics is super important.
So again, we've learned a lot about rotator cuffs and rotator cuff injuries, as well as the reverse, what do we call it? The
Reverse total shoulder. It's a
Total
shoulder
shoulder.
arthroplasty. We kind of covered the spectrum of that.
Yeah. It looks very fancy, and that's not what it would look like, right? That's
Oh, it would.
It would?
That's exactly what it looks like.
Interesting.
It's clear
It's
so
very
you can see where it
Terminator-ish.
attaches to the
I
bone.
see.
Yeah, exactly.
Okay.
I call it the bionic shoulder when you come back.
yeah,
So-
it has the space for the anchors, like you
Exactly,
said.
exactly.
Interesting. Well, we've learned a lot today, and we had some visuals, so that always helps. We want to thank Dr. Callanan for coming in for our Healthline 3. And again, if you want to reach out to his office is located on Piermont, and it's at the or on 70th Street, right? And it's the Willis Knighton Orthopedics and Sports Medicine office at Piermont.
Yep, Portico Center, easy to
Portico
find
Center.
us.
Fantastic. Well, thank you so much for joining us today. And thanks to our callers. And again, this Healthline 3 has been brought to you by KTBS 3 and the folks at Willis Knighton. Have a great day, everyone.